Welcome to this A4 Medicine clinical update on NICE Technology Appraisal TA1152, Semaglutide for cardiovascular risk reduction. My name is Rahul Srivastava. In this short session, we'll walk through the new NICE recommendation, clarify exactly who is eligible, summarize the select evidence base, and discuss what this means for prescribing and funding in routine NHS practice. The guidance was published on 7th May 2026, and the focus here is very much on how you can apply it safely and confidently in day-to-day clinical work. NICE now recommends semaglutide as an option for reducing the risk of major adverse cardiovascular events, that is, cardiovascular death, non-fatal myocardial infarction, or non-fatal stroke in a defined high-risk adult population. The dose used for this cardiovascular indication is up to a maintenance dose of 2.4 milligram once weekly, delivered subcutaneously. Importantly, semaglutide must be used as an adjunct to lifestyle measures, so patients should remain on a reduced calorie diet and be supported to increase physical activity. This is not a substitute for lifestyle change. For patients who meet the criteria and where clinicians judge it to be most suitable option, funding in the NHS in England is mandatory under the technology appraisal. Who exactly is eligible? NICE focuses on adults with both overweight or obesity and established cardiovascular disease. Overweight or obesity in this context is defined as a body mass index of 27 or more. Established cardiovascular disease means a documented history of cardiovascular disease, which we'll unpack in more detail on the next slide. To qualify for semaglutide under this appraisal, patients must meet both criteria, BMI at least 27 and established cardiovascular disease. Let's break down what NICE means by established cardiovascular disease for this indication. Patients qualify if they have had a previous myocardial infarction or a previous stroke, and that includes both ischemic and hemorrhagic stroke. The third qualifying group is those with symptomatic peripheral arterial disease. Within PAD, NICE highlights several examples: intermittent claudication with an ankle brachial pressure index or ABPI under 0.85 at rest, a history of peripheral arterial revascularization, or an amputation attributed to atherosclerotic disease. So in practice, you're thinking about your secondary prevention population, prior MI, prior stroke, or symptomatic PAD plus a BMI of at least 27. The key evidence driving this recommendation comes from the SELECT trial. SELECT was a large multinational randomized double-blind placebo-controlled phase 3 study that enrolled more than 17,000 participants. All participants had a BMI of 27 or more and established cardiovascular disease, mirroring the NICE target population. People were randomized to subcutaneous semaglutide 2.4 milligrams once weekly, plus a standard care, or placebo plus a standard care, with both groups continuing guideline-directed cardiovascular therapy. It is important to note that SELECT excluded people with diabetes and those with very recent cardiovascular events within the previous 60 days, but NICE has still chosen to recommend semaglutide in those groups in practice. That's because the mechanism of benefit appears at least partly independent of weight loss, and the reduction in events is seen relatively soon after starting treatment. So what did SELECT actually show? The primary endpoint was time to first major adverse cardiovascular event, cardiovascular death, non-fatal MI, or non-fatal stroke. Semaglutide was associated with a hazard ratio of 0.80 for first MACE, that is major event, with a 95% confidence interval from 0.72 to 0.90, which equates to 20% relative risk reduction versus placebo. Looking at the component endpoints, non-fatal myocardial infarction had a hazard ratio of 0.72, non-fatal stroke 0.93, cardiovascular death 0.85, and all-cause mortality of 0.81. The direction of effect was consistently in favor of semaglutide across these outcomes, and many were statistically significant, supporting a genuine reduction in cardiovascular risk rather than a chance finding. In clinical terms, this offers an additional tool on top of statins, antiplatelets, blood pressure control, and lifestyle measures for secondary prevention in people with raised BMI. NICE also considered whether this benefit represents good value for NHS. In the economic model, the incremental cost effectiveness ratio for semaglutide compared with standard care ranged from about 6,878 to 14,594 pounds per quality adjusted life year gained. These figures sit comfortably below the usual NICE threshold of around 20,000 pounds per QALY. So semaglutide was just to be cost-effective use of NHS resources in this indication. The modeling assumed that healthy lifestyle counseling offered alongside semaglutide would be similar to what is already provided as a standard care for people with established cardiovascular disease. So no major additional implementation costs for lifestyle support were built in. Overall, NICE's verdict is that semaglutide delivers meaningful cardiovascular risk reduction at a cost the NHS can justify. In terms of implementation, NICE TA1152 appraisal was officially published on 7th May, which is very recently. For England, there is a strict 90-day implementation window, meaning that by around August 2026, semaglutide should be routinely funded for this indication wherever it is just clinically appropriate. Integrated care boards, NHS England, and for their public health function, local authorities are required to comply with this appraisal within the 90-day period. The key practical message is that if a patient has established cardiovascular disease, a BMI of 27 or more, and you as a clinician feel semaglutide is the right option, it should be available in line with the NICE recommendation. To finish, here are the key take-home messages. First, eligibility hinges on both established cardiovascular disease, previous myocardial infarction, stroke or symptomatic peripheral arterial disease, and a BMI of at least 27. Second, high-quality evidence from the SELECT trial shows that semaglutide, on top of standard care, significantly reduces the risk of major adverse cardiovascular events, including cardiovascular death and non-fatal MI, with consistent signals across related outcomes. Third, because the cost effectiveness is well within the NICE's accepted thresholds, NHS funding in England is mandatory within 90 days of the guidance publication on 7th May 2026. So patients who meet criteria and for whom it is appropriate should be able to access treatment. Thank you for watching this A4 Medicine update on NICE guidance. And please subscribe to our YouTube channel. And please share these resources with colleagues who may find them useful in practice. Thank you.